tirzepatide, first dual agonist, and upper gut and alpha islet cells are what secrete the GIP, the glucose dependent insulinotropic polypeptide. Our lower gut is where we get the GLP-1. And they help to increase insulin. So we get huge control with blood sugars. Here's the peptide sequence. It's 39 amino acids, and here's the weight and formula. It comes from literally a dragon. And what's awesome about it is it has a long life because they modified it, just like semaglutide. It's acylated and it has a fatty acid modification. One part of it is the N-terminus of the JEV frag, and that's human homology. However, there's an intermediary section, which is dragon. It's this Gila monster. It's modified fragment from, it's an amidated xanthanide like C-terminus. And that gives it really great activity. Together, the structure binds JEV really hard and fast as fuck, but then it's weaker on the GLP-1. So it mimics our natural affinity for the endogenous receptors. And it's just, pretty incredible. And I think that's why the side effects are somewhat less with tirzepatide. We don't hear the same amount of hypoglycemia. We don't hear the same amount of fatigue or hair loss so far. And what we see in clinical practice and anecdotally in the community of, and what I see for myself and our clients and myself is that maybe when people get off it, there's a little better reset for the basal metabolic rate, as well as our set points, our weight set points. So we are kind of hybrid when we're using this because it is a dragon peptide. And it comes in different forms. The compounding pharmacies all have it. Again, on the earlier link with semaglutide, limitless life nootropics is my research lab for certain peptides, many peptides. And pharmacies have it available. It comes in pre-filled syringes. There's 6 available dosages because it goes maximum all the way up to 15 milligrams. These are the reported side effects: low appetite, blood up to 19% of people report the low hypoglycemia, but this is because they have basal insulin on it, which is good to note. There's some nausea, vomiting. The thing is, it's more explosive. The onset might be 6-8 hours later. Semaglutide might be a day and a half before the onset of symptoms, or when it starts working, there's a delay. Tirzepatide seems a little quicker, and it might be like, if the dose is too high, people seem to report huge nausea and vomiting, and even explosive vomiting 6 to 8 hours later. It just like hits them. So, and there is some reports, 0.5% of acute bladder disease. And I don't know if this is related to the rapid fat loss, where you need to have ox bile on board or some TUDCA. And it has the same black box warning. In rodents, they were given toxins, and they saw thyroid C cell tumors show up. So it's contraindicated, of course, with anyone with that or any kind of multiple endocrine neoplasia. And I do think it's good to have, when you're doing the commitment for clients, to have this as one of the coaching commitments, that they disclose, any risk for cancers and any potential for pancreatitis, what their alcohol use is, maybe if they've had a thyroid scan, if they've ever had any issues there. I like to know which one of my clients have nodules, because usually in 2 months or less, we see these go away. The protocols just really help with that. And keep those all in mind. The contraindications are pretty much the same as semaglutide. Anyone with those prior cancers, absolutely no. Any history of pancreatitis, any history of other things. There is rapid changes in blood glucose, more with tirzepatide than semaglutide. And so they have a warning here. There's temporary worsening of diabetic retinopathy. Tirzepatide has not been studied with patients with non-proliferative diabetic retinopathy requiring acute therapy, proliferative diabetic retinopathy, diabetic macular edema, or other forms. Yeah. So there are a lot of obesity studies. It has not gotten the FDA approval yet for treating obese. So there's a lot of off-label use currently right now. Here are the phases that are going on. Now, there are a ton of tirzepatide studies, and they're head-to-head against liraglutide, dulaglutide, And literally in every one of them, they show they're better. Like tirzepatide does not fuck around. So here's just a review of, they had a review and they looked at all the GLP-1 agonists. And as it was a big meta-analysis, systematic review. And I think it's interesting. Sometimes they use semaglutide 1 milligram, which they showed better weight loss, better insulin control. But even at the 2 milligram dose, the max, close to the max dose of semaglutide, it was quite better. So these are, millimoles per milliliter. If you want to convert it to hemoglobin A1C, this is how I think. You can see tirzepatide, it was, this is how much better it was than the first line is GLP-1 agonist. The second line is using basal insulin. And the last line is the placebo. So it can be as an improvement as much as like that much for hemoglobin A1C, which is really huge for diabetics. Even 6% A1C, that means they start perhaps at a really high level of A1C.